Good evening, everybody. I'm Assemblymember Laura Friedman, and I want to welcome you to our town hall tonight. Tonight's town hall will be about emergency preparedness in the medical space, particularly around our response for pandemic. And the question we want to answer tonight is whether we are in better shape right now after the COVID experience to deal with any pandemics that might be coming our way. But before we get to our amazing panel, we do have a special important public announcement about the COVID-19 preventatives for immunocompromised individuals that's available through LA County Department of Public Health. We have with us today Marcella Sidok-Chak from Farm D from AstraZeneca, who's going to be presenting on a vaccine called Evusheld. Marcella is the Senior Medical Science Liaison who works on U.S. immune therapies and vaccines, including COVID-19 protections for immunocompromised people. And the reason that AstraZeneca asked us to present this today is because we have a large subset of our population who really can't take the regular COVID vaccines because either they're immunocompromised and the vaccines don't work on them, or maybe they're allergic to the vaccine. And we wanted to let people know that there are alternatives that are highly effective. So I want to thank you for joining us, Marcella, and the floor is yours.
Thank you, Assemblymember Friedman. Let me just share my screen so I can show my short presentation. Let's see here. Sorry about that. Slideshow. Okay. Well, thank you again. So thank you for the introduction and for joining me this evening. And let me just minimize this here. So again, we're going to be just going briefly over what Evusheld is. And Evusheld is basically a combination of a monoclonal antibody that consists of two components. And similar to what Assemblymember Friedman had said is that we're looking at basically a population here that is moderately to severely immunocompromised. And with this population, we do understand with the current pandemic is that there's two groups where those that are being vaccinated with the COVID-19 vaccines are not able to mount a very good response, like someone who is healthy. And then as well as what was mentioned earlier, there are individuals who are, for whatever reason, are allergic to the COVID-19 vaccines. And thus, this is also an alternative for those individuals as well to provide them with a vaccination in that case for some protection against severe COVID-19 disease. So where the CDC comes from is that basically we do understand when we're looking since the beginning of this year, looking at the past 2 years, over 22,000 patients that were observed in a study that were hospitalized for severe COVID-19 infections, that there was nearly 12% of those individuals that were classified as immunocompromised. Now, what we also understand is that there is evidence that actually shows that individuals who are moderately to severely immunocompromised are also at higher risk of being admitted to the ICU, as well as dying in the hospital from a very severe infection of COVID-19. So if we were to look at these individuals who are compared to healthy individuals who were unvaccinated, they share the similar risk as being immunocompromised and getting vaccinated as far as likely being admitted to the ICU or dying in the hospital because of that layer of protection that is needed. So what do we understand right now for COVID-19? So we understand that there's vaccinations, that we have choices now, that basically individuals 5 years and older are able to get vaccination. But we do know that as far as immunocompromised individuals who are mildly and severe are not able to mount a very good response. So in those cases, they also do need another layer of protection, which is where we have Evusheld in the second column for pre-exposure prophylaxis. So then on the treatment side, we do have treatment for mild to moderate patients. And then also for inpatient, we have those that are moderately severely infected as far as treatment modality for them as well. So when we look at Evusheld, Evusheld again is a long-acting monoclonal antibody who's been tweaked to be long-acting compared to other monoclonal antibodies. They're primarily two antibodies that are working in complementary activities, meaning that they hit at different points of the virus, and this preventing that virus by attaching itself to any receptor site in the body, and that's how it prevents disease or the infection. So again, Evusheld can retain as far as activity against the circulating virus, which currently right now is the BA.5, BA.5, and other circulating variants as well. And so individuals who are started with Evusheld, the recommendation is every 6 months for redosing if needed, if their condition and added protection is suggested. So as far as availability, this is where all doses of Evusheld is provided by the federal government, and the federal government in partnership with the state and territory health departments partners with systems and other sites of administration to have this product available for administration. So where we are today and why we're here this evening is that there has been some potential barriers as far as insights that we have gathered through patients and from healthcare providers, that many are still not aware of the availability of such a product for individuals who are immunocompromised that may not tolerate the COVID-19 vaccines, as well as the immunocompromised patients that do need that extra layer of protection because they're not able to mount sufficient as far as mounting of sufficient level of antibodies even after receiving COVID-19 vaccines, as well as just providing that awareness and education for healthcare providers and patients alike. So before I hand it off back to Assembly Member Friedman, I just want to remind everyone that there is another option, and we'll be more than happy to answer any questions later and provide any information. So again, we thank you very much for this opportunity. So I will hand it back to you, Assembly Member.
Thank you. And let me just, in case people didn't hear it, what is the cost to receive Evusheld?
So the product itself is provided by the federal government, so there shouldn't be any cost associated with the product. I can't say as far as the administration portion that is involved with administering the product, so that would vary.
But it should be, it should be free for most people. For most people,
yes.
Well, great. Thank you so much, Marcella, for all of that information. And I'm sure that there's people out there that that this really could help. Information about this vaccine is found on the LA County's public health site, and the link is being provided in the chat, I believe, right now. So if anybody needs that, they can find it in the chat. And if for some reason you can't access that, you can always contact my office and we'll get you that information. And that's the case with any information you hear on this Zoom. If you need any more information from anybody and you have trouble tracking it down, you are all welcome to contact our office directly if you have questions later on, and we'll try our best to get you answers and to connect you with resources. So again, thank you so much, Marcella, and thanks for sticking around with us. And I want to thank all of you who are watching us tonight for being here on a Tuesday evening to talk about disease preparedness. Your questions are always going to be welcome. And if you have any questions during this chat, please go ahead and send them to us through the Q&A feature. And those of you who are watching on Facebook are welcome to ask any questions in the chat, and our staff is going to monitor that and try to send us any questions that you have. And we will also try to get you, again, if we don't get to all your questions, and we usually don't get to all the questions, we'll do our best to answer them. And if you just put your contact information in the chat as well, we'll try to get the answers directly to you. Now, certainly this pandemic has challenged and revealed some of our flaws in our support system and in our healthcare system. And that's why I'm really excited about tonight's discussion, because I do think it's important to have more dialogue to find out how our local institutions are now better prepared for pandemic, how our public agencies maybe have changed their response, and to be sure that we're always able to protect the most vulnerable population members among us. We have an amazing group of panelists here this evening, and I want to thank all of them for joining us tonight. Each of our speakers has been doing deep work in the healthcare field, and they all bring valuable insights. So with us here tonight, and I'm going to give very brief introductions, is Dr. Tan Terashita from the LA County Department of Public Health. She is the Associate Director of the Acute Communicable Disease Control Program, Emerging Outbreaks and Virology at the county level. She's been at the forefront of handling monkeypox here in LA County. And LA County is also seen as its own jurisdiction by the federal government. So that's a big responsibility. Dr. Caroline Kurtz from the California Department of Health is the lead of the COVID-19 local coordination team at the department. She facilitates and coordinates time-sensitive partnership work and communication between local and state public health leadership, and she's been doing that since March 2020. She's worked on statewide initiatives such as the County Data Monitoring Program, Blueprint for a Safer Economy, and equity-focused outreach for COVID-19 vaccinations. Carl Keeler from our very own Providence St. Joseph Medical Center here in Burbank is the chief executive of that hospital. He brings 30 years of healthcare experience, starting as an emergency medical technician at a Utah clinic. He went on to hold positions in business development, physician partnerships, and administrative management in several states. And Josefina Alvarez Mena is from California Reducing Disparities Project. She's the leading voice with that program, which is also called CRDP, which was founded in 2009 with the goal of achieving mental health equity for 5 priority populations in California: African American, Latino, Native American, Asian and Pacific Islander, and LGBTQ+. The CRDP is funded by the Mental Health Services Act, which was passed by voters in 2004. The purpose of this act is to expand culturally and linguistically competent approaches to underserved populations. So I'm going to address questions to different panelists, but of course, all the panelists are more than welcome to just let me know if you want to answer, or just go ahead and chime in. So LA County is recognized as its own jurisdiction by the federal government. What advantage is that for LA County in terms of emergency preparedness, and are there any disadvantages? And I will ask Dr. Tereshita to maybe kick us off, and then anybody else who wants to respond.
Hi, thanks for that question. Yes, we in LA County, we appreciate being recognized by the federal government as our own jurisdiction, especially for COVID. LA County has a population of over 10 million, making us bigger than 42 states. Being recognized as our own jurisdiction is really about resources. It gets us resources quicker, and we're able to use those resources as appropriate based on what is very important local data. Now, there can be disadvantages. I think the biggest disadvantage is being recognized as a federal jurisdiction, as well as being part of our wonderful state of California, means we have essentially 2 bosses. It does require a lot of coordination and communication, but this is easily accomplished.
Great. All right. I don't know if any of the other panelists want to add anything to that.
Yeah, I would. I appreciate what Dr. Tereshita said. I think absolutely it is definitely an advantage for federal recognition of LA as large and as diverse it is. But I do echo that we have had such substantial and really significant partnership with LA County, especially during the COVID response. Extremely appreciate all the bi-directional communication. I think that has been a hallmark of the communication, not only just with LA County, but with all of our jurisdictions, that really our local public health departments are an extension of the state. We're partners, even though there may be a funding relationship. We're really partners in this together to really think through the problems and think through the issues. And that was definitely needed during the pandemic in the early stages and even today.
So it sounds like there's been some sort of coalition building between these different agencies, which is great. What areas do you think could still be strengthened? Anything?
I mean, I'll jump in from the perspective that, we all know that COVID has been the most significant emergency that we all have faced, not only in California, but in the country and the world. And in California, particularly with being as large and diverse as it was, being able to have a whole of government approach was such a huge undertaking. And not only that, but things changed so quickly. We know that our systems were stretched beyond reason. Emergency response was so different from what it was before, and we had to do things rapidly. And so that partnership, the bi-directional communication that we had with not only LA County, but other jurisdictions in the state in real time, quickly really proved to be what was needed to be able to learn from it. But we also figured out that our infrastructure was maxed out. And so to date, we have developed the Smarter Plan, and we have also really worked to make sure that public health investments, infrastructure investment has actually taken place. And so there's definitely been some improvements. Our partnership and communication is very fluid and constant, and just really super proud that we're able to have now ongoing funding to all of our jurisdictions to shore up public health infrastructure. In fact, LA County and all of its departments get 25% of the $200 million investment that we are providing to local public health. And so we definitely think we've learned, and we're really excited about how that's going to prepare us for future emergencies.
That's great. And let me ask Carl and anybody else who wants to answer. It seems like the funding that comes down, that comes to hospitals and comes to agencies fluctuates, and it's not always consistent. How do you prepare for that ebb and flow in funding?
Well, I think the big piece around the funding is, we do get emergency preparedness dollars, but it is sporadic. So there are times when we'll see a bolus of that, and then other times we don't. So for us, what we look at doing is how do we really train our staff so they're prepared? So we do events every year with regard to any type of emergency or any type of pandemic. So and what's really helped us is now our training is much better. How do we communicate what's happening? Because with this pandemic, usually when you train for an emergency, it's a very limited time, where this has been over multiple years. So how do you continue to be, where at first we were heroes, and then you transition, and how do you work through all the mental health issues, the workforce issues, just the burden of supply chain issues. And so for us, it's making sure you have processes in place that from a supply chain, from the workforce, from a training that can sustain whether you are getting funding or you aren't.
Let me ask about workforce, because we heard a lot during the pandemic about shortages in the medical profession. We heard about nurses flying around the country, about hospitals being unable to compete for adequate medical professionals. At the same time, medical professionals really facing a lot of stress at work, overwork, people leaving the field. And I've heard a lot also about just not having enough medical professionals being trained or being in certain areas. So are we ready for another pandemic in terms of workforce? And do you feel that enough's being done to attract people to the field, to bring them into different areas? And kind of I'm going to ask all of you this actually, what is your particular role when it comes to developing and retaining workforce?
I think we're ready from the fact that we now know how to train in large scale. We know how do we communicate when things change, and what to do to get people, before hospitals and healthcare, it takes slow to make those changes, but we were able to innovate very quickly and change process, and how do we work with all the governmental agencies to make. So from that perspective, I think we're much better prepared and ready for this. But from a workforce perspective, we have struggled. So we've had a number of people that have retired early. We have a number of people that have just left healthcare overall. From a nursing perspective, the agency or travelers was a significant impact. For our organization, Providence Health, we had an 80% increase in our what we would pay normally for a traveler. You would only use those when you had specific emergencies, but we had an 80% increase, which was almost 600 million difference from pre-pandemic to the year directly after the pandemic. And so, from an organization, that's significant. And when you look at burnout, mental health, significant difference. Pre-pandemic, 1 in 5 or 20%, came in with some mental health issue. During the pandemic, that jumped up to the mid-30s. And you saw that not only in our patients coming in, but also from a workforce perspective. So for us, it's the pipeline. There just aren't enough being trained, both from a nursing perspective, from we are looking far and wide to make sure we have enough staff to provide even just the basic services now, let alone if we have another pandemic, that will be a challenge. Because if you a nurse, you can't just produce one in 3 months. It does take multiple years, and it's not just nursing, it's pharmacists, it's our techs, it's kind of all aspects of care. For us, one of the challenges was even screeners. How can you even get screeners doing temp screening and other things, which we had a significant challenge putting in place. So working with the state to try to be innovative on what programs can we put in place to help get more people into the healthcare field is something that we need to do much more of.
So it sounds like we're not really there yet, that there's more, maybe a lot more awareness that this is important and a bit of a crisis, but we haven't figured out exactly how to do it.
We absolutely haven't figured out how to do it. And we do have some challenges in the state with some of the regulations we have from ratios and other things. It does make it a challenge to be innovative. And how do you do things differently? So there are some challenges. And we are in a place where we're even having hospitals, because of some of these, from an increase in supply chain costs. When you look at our pharmaceuticals, they go up, it's double digits for the last 3 years. And just staffing, our staff costs increase. We've just seen in LA County, we had just last week 4 hospitals that filed for bankruptcy as part of pipeline healthcare. So unfortunately, that's a challenge. There's just a lot of pressure, at least from a hospital perspective and the physician's perspective, that we are going to see more challenges as we're trying to get more people in the industry.
Would anybody like to maybe add any other perspectives on that?
Yeah, this is Dawn Terashita. I think we are both prepared and not prepared. I think one of the lessons we learned is that surges happen during pandemics, and it's one of the hardest things to prepare for as far as staffing goes, because you're going to have times when you need to surge up staff. One of the lessons we learned really was about planning. I think planning is key. We learned how to forecast and model and prepare. We know winter time is a time we're going to see surges. We can look to other countries where we see surges happening that precede ours. So like we can look to Europe in some cases for flu. We look to the Southern Hemisphere like Australia in order to be able to plan, because bringing on staff for surges is tough, because then when the surge goes away, the work for those staff go away. And it's really having staff who are ready to mobilize quickly, having rooms in hospitals to mobilize quickly, masks, gloves, ventilators, beds, all those things quickly. We're using a lot of our funding and resources that we've gotten from the federal government through different funding, like the Public Health Emergency Preparedness grants, to look at sustainable long-term funding for these surge capacity, which again is important.
That's great. So we've talked about staffing. Are there any other challenges that have emerged for providers, major challenges besides staffing? For instance, you mentioned hospital bankruptcies, you mentioned the staffing issues. Is there anything else that's come out of COVID that we haven't solved, that's placing a lot of stress on medical systems?
Well, I would say just the supply chain issue overall, just making sure we can get access to pharmaceuticals, to supplies, that continues to be a challenge. So even as we look at getting that the medical equipment, because of what we've seen from a supply chain, making sure we can do that are some challenges. I would say really the mental health issue that has been exacerbated because of the pandemic, and we still are seeing significant effects. If you look at what's coming in our emergency departments, every patient has some mental health challenges that we're facing. So how do we continue to bolster support for mental health, and quite frankly, even for our organization, housing? How do we have affordable housing in locations to help make sure that we can have all the staff and the appropriate staff that are close to our critical resources? And that is another one of those challenges that we need to look at and how do we address.
I feel another challenge that we have to talk about is data. I know it's not a very sexy topic, but it's something that we've really had to ramp up during COVID. We went in LA County from having tens of thousands of total diseases reported to us in a year, to millions of cases of just one disease reported to us in a year. Our communication systems really need to be able to speak to each other, both with hospital systems as well as the state and federal governments. We need to be able to quickly tell our leaders about what important metrics they need to be looking at so that they can plan and make their next steps. Another thing we learned is that there's still health inequities across the county and across the world. There's certain micropopulations that we have trouble reaching for the most important things, such as targeting with medications and vaccinations. We've gained a lot of knowledge about important partners. We need to collaborate, and I know we have some of them on the call today, but I'd just like to highlight that. Thanks.
The data set question is interesting. I mean, how do you use data sets to monitor outbreaks? Anybody want
That's a good question. Yes, I'm sure our my state counterpart has a lot to say on this too. We in LA County, we use one system. It's called the Integrated Reporting, Investigation, and Surveillance System, or otherwise known as IRIS. We like the flower acronyms. We use this as it's where physicians will report data into, such as hospitals will report cases of COVID. We also use it for investigation or outbreak management. And then, of course, we also use it to do data analysis and monitor trends in our community.
Great. Now, Carl, were you going to say something?
Yeah, I was just going to say quickly. And for us, for hospitals, we use the data for planning. So to know when we think we're going to get surges. So we would look at, to try to plan. So using the data from the state and local agencies around, how do we plan for those surges? So we make sure we put as many resources when we think we are going to see those peaks and valleys. And that made a huge, as we started the pandemic, it was much more difficult to do the prediction. But the further on we got, the predictive models were much better and really helped us make sure we had resources in the right location and that we could borrow, whether it was supply chain things or, whatever. So the data made a huge difference in at least the planning for the provider side.
I just want to echo what my fellow panelists have said in terms of just how important the data has been and how it has changed so much and how quickly we had to really ramp up and improve our processing of data. Certainly there are many other colleagues at the California Department of Health that can speak more to this in depth, but just overarchingly, wastewater surveillance, modeling data, being able to have data in real time, which is something that we're working on. And as part of the investment in the future of public health, want to be able to increase that 24/7 decision-making intelligence hub to be able to do that again in times like the surges. But having things like modeling and understanding the potential new variants that are out there does help with what Dr. Tereshia said with the planning, that having that information helps contribute to really thinking ahead before it actually comes upon us, which, by the way, was exactly what we were faced very early on the pandemic. We were in constant reactionary mode because it was so new to all of us. We didn't know what we didn't know. And so over time, we were able to figure out these are the types of tools that we needed to improve and increase visibility on and sharing with our partners, such as healthcare providers, such as local public health departments. So I would totally echo everything that has been said so far, that is definitely a lesson learned and definitely where room for improvement and investment continues.
I guess in hindsight, there have been experts that have warned us about pandemics and about viruses for a long time, and warned that with people traveling more around the world and going into places where people haven't been as much before, that there is a lot of risk of more zoonotic diseases emerging and viruses that we haven't seen, and moving around much more quickly. They're not contained as much because people are getting on airplanes and traveling. I mean, it really does feel like in some ways we're at war with these viruses, with these little animals. How do you monitor where they are and what's out there? How do you just wait for cases to hit a certain tipping point in hospitals, or are there other ways that you're trying to stay ahead of the viruses?
So it's a very multi-pronged approach to disease surveillance. The main way we monitor key diseases is through our reportable disease list. And in the United States, these are controlled by the states. The state sets what diseases we think it's important to monitor. Right now in California, there's roughly between 80 and 90 diseases and syndromes that are reportable by law by clinicians. or facilities like hospitals to public health. And it goes from the clinician to local public health to the state. And then ultimately the federal government can see trends in very important infectious diseases. And obviously this list doesn't contain all of the potential diseases. So we also rely on just our general consult physician, clinician reporting lines to public health to call us about anything very unusual, especially in travelers. This is a question we encourage all clinicians to ask, especially for severe infectious diseases. And it's another way of kind of monitoring what's going on. There's lots of other surveillance systems out there looking at diseases from around the world. We're looking into a lot of new technologies where data can be mined to automatically look for data clusters in certain geographic areas and in certain time periods. So that's all happening. We have different modeling studies that are going. We have a lot of new data technologies around that I'm sure some of my colleagues want to talk about, but it's very, very multi-pronged. Very proud of the system we have though.
And I read that they're now monitoring wastewater. Can someone explain how that works?
Yeah, so it's something that LA County has been doing for a while. And a lot of other countries and states have done it as well. So one of the things we've been doing is wastewater surveillance for COVID. We've been doing this since the beginning of COVID. Where we look at, we partner with some of our sanitation districts in LA County. We have 3. We partner with them so they do some sort of regular surveillance, and each one does it a little slightly different, but they take samples of their wastewater and they look for whatever the disease we're interested in. Right now it was really COVID. We're also looking at monkeypox at the moment to see. And based on the sanitation district's geographic area, we can see what concentrations of the disease we're looking at are. So we can tell right now we have COVID circulating in all of our wastewater districts. It's based on the premise that humans will excrete the virus in their waste, in their sewage. And some people are symptomatic, some people are asymptomatic, meaning they have no symptoms. And the system can and should be able to pick up viruses or other infectious diseases quickly and tell us maybe before people are even symptomatic that we have a disease circulating.
Wow. What can we in LA County do to help? How can we be vigilant? How can we add to whatever data we need to help out? Is there any role for private citizens in this, or is this all something that the county needs to do?
Well, we have a really cool system right now in LA County. We have what we call Angelinos in Action, which is a community-based SMS or text-based symptom monitoring for respiratory diseases. So you can sign up, the community members can sign up, and they can be texted once a week saying, do you have any respiratory symptoms in the past week? And if you say yes, it's followed up by I think it's 2 more questions. One is, do you have a fever? One is, do you have a cough? And that's it. And based on the text, the phone number you give us, we will be able to calculate the amount of people reporting disease in a particular week. And we've used this, and it's actually been a very interesting program that has shown preceding spikes in our SMS texts before we actually see surge in humans, which has been very interesting throughout COVID. So it's something a person can sign up for.
Wow. I want to switch to Joselita Mena now and just ask a couple questions. First of all, I know that you work on vaccine equity, and I'm wondering, do you feel that we are focusing enough on that, and how are we improving equity in the vaccine world? And we'll loop back to the presentation we had from AstraZeneca, feeling that they have this great vaccine for people who can't take the regular COVID vaccine, but it's not being utilized to the extent that they feel they need to, that maybe it's not getting to the people who really could benefit from it. So how are we doing in that respect, and what could we do better?
Well, I think we have work to do in that respect. And it's very, I think, challenging to talk about vaccine equity in isolation. And so it's really a larger equity issue. And when we think about vaccine equity, we also have to consider housing equity, educational equity, economic equity. It's very hard to convince someone to go and get a vaccine if the public health information is not in their language. It's also very hard to convince someone to go out and get the vaccine if they don't trust the messenger.
Mhm.
So a lot of our work has focused on putting people in the position of being the messengers that reflect the community that we're doing the public health outreach to. That is a best practice. We need to really focus on creating larger cohorts and cores of trusted messengers within the communities that are, accessing the vaccines and other treatments at lower rates. If we want to be able to say that we're coming out of the pandemic, really. And so we have a lot of work to do in that respect. And I think, it's not rocket science. If you are working 2 or 3 jobs, when do you take off to get the vaccine? If you don't speak English and you're handed some information in English, or you get a text message in English telling you about the vaccine, it's not accessible to you. So we have to really get to the level of communicating to people where they are and creating opportunities for them to access the vaccines.
And we all know that the COVID crisis has led to a lot of impacts on mental health. I mean, clearly people had a lot of anxiety. I saw it in my own daughter, who was, 7 and 8 years old at the time. And for a while, I mean, I'll be honest, she was afraid to go outside for a while because she knew there was something bad out there. And I have no idea what kind of effect that's going to have on her and a lot of other young people and children. I certainly know there are college students who missed their senior year. People who just had anxiety over not being able to go to work, losing a job. My office dealt with thousands of people, helping them with EDD. It was extremely stressful for people. So how are we making sure that the populations that you're focusing on for vaccine equity are also receiving the mental health support that they need?
Well, just like there's inequity in terms of vaccine access, there's inequity in terms of the mental health services. And so we know that the pandemic has had just a tremendous impact on mental health. And we also know that underserved, marginalized populations have been disproportionately impacted in terms of their mental health. And we have seen exactly what you've described in young people and older people and seniors, increases in depression, increases in anxiety, increases in suicidality and PTSD. Now, this impact has really overwhelmed the mental health system, not just in California, but really all over the country. And in order to address the mental health impact or begin to address the mental health impact, we have to address the mental health disparities that exist within the mental health landscape. We do not have enough services that are culturally and linguistically appropriate. And the state of California, before the pandemic, had begun to address this as part of the California Department of Public Health's California Reducing Disparities Project, which was focused on funding and studying community-defined practices that better meet the needs of some of the marginalized populations. There's 5 populations that are part of that initiative: African Americans, Latino, Latinx, API community, Native American, and LGBTQ plus communities. And those, there's 35 programs across the state funded through that initiative. The 35 organizations that are part of the CRDP were hit by the pandemic. And because they were strategically positioned within our communities, they were able to respond not just to the mental health need, but also to the need for basic services like food. And so many organizations were able to stretch, address the support needs of young people, of families, of seniors across the state and across those 5 populations. Now, we were not specifically funded to do that, but because we were, again, strategically positioned, this was part of California's response to the pandemic, and we were able to meet critical needs at a time when many other institutions could not respond as quickly. Now, the state legislature, to its credit, expanded the CRDP and invested another $63.1 million in the 21-22 California budget to really try to scale community defined practices to better meet the needs or, complement the existing services and programs for these populations. This is a very concrete and important strategy to address the mental health disparities that have been exacerbated by COVID.
And Assemblymember, if I can just add to all the really important points that Josefina has brought up in terms of what was so critical on the ground to be able to meet the needs of those that are most vulnerable. Absolutely agree. At the state, we recognize that so acutely during the early days of the pandemic and throughout it, and has invested $50 million in partnerships with more than 200 CBOs throughout the state to do exactly what Josefina described: be trusted messengers, do canvassing, actually help set up appointments for vaccinations, having that voice and that partnership, being a face that looked familiar was really important. We recognize that, and we recognize that needed to continue. And so through state and federal funding, we are funding local health jurisdictions, CBOs, to put in place vaccine equity plans that are for the next 2 to 3, 4 years. So it's really important that we learn and have learned from organizations like Josefina to replicate that and do things like that on a statewide level, and super proud that we've been able to do that to the extent we have. And then as a result of that, even if we weren't funded to do it, developing these really important partnerships across all these different organizations has positioned us well to be basically integrated into the fabric of our communities, to have these trusted messengers, these trusted organizations. And so, the Smarter plan that the state has put together takes advantage of that, recognizes that that's really important to continue to do. And then on top of that, you asked a really great question, Assemblymember, of what can the public do? What can individuals do? There are very simple things that can be done. The state has put together and has launched CA Notify, which is an exposure notification via your smartphone. Every single person we know has a smartphone. And so if you're able to turn that on, it's optional. You're able to notify people anonymously, if they have been exposed. So that's a way of being able to sort of crowdsource information. The trusted messengers, that's also been really important, and to volunteer or to opt into programs. The state has funded a number of what we call neighborhood partnership programs, which are grants to actual neighborhoods, not cities, not counties, but neighborhoods who want to take on that role to do on the grassroots efforts. And really proud to say that out of the 557 grants provided throughout the state, over 200 of them are in LA County, representing over $1 million of grassroots efforts to neighborhoods. So I can't echo enough and reinforce how important the messages that Josefina has mentioned is really important. And collectively, what both Carl has said, what Josefina has said about mental health, it is an absolute priority of the state. It's a priority of our agency to address mental health and behavioral health issues. And I know it is absolutely a priority of our local public health departments throughout the state of California.
Now our challenge is making sure we have providers that can deliver the necessary care. So it's not only communicating and demystifying the issues with regard to mental health, but do we have enough providers to provide the care? So there was a study done in 2021 with regard to care to Californians. So a study of Californians that looked at care delivered in 2020, and a question was asked with regard to did they have a mental health issue and did they receive care for it? 44% said they did not receive the care they needed. So, when you look at that, that is a significant challenge. It doesn't have to be a hospitalization, but just from the basics, we don't have enough healthcare resources or providers, or quite frankly, funding to get those to provide those needed services that, again, it was woeful before the pandemic. It's been exacerbated by the pandemic. And so that's the challenge. How do we make sure we have the actually care resources that match kind of the other pieces of the disparity issue, because we just don't.
So it sounds like another need that we know we have that we're not really ready yet with, even for the current need, much less any future need. What about people that are watching right now? If they feel that they have that gap and they need mental health care, what would you recommend? Do they go to an insurer? Do they call a hospital? What should people do?
I would recommend that they go to a provider that is accessible to them. I mean, you should be able to access treatment when you need it. And that's all along the continuum of treatment. There's a number of different modalities that people can access. They should, try to get the treatment that they need as soon as possible. In addition to that, more long-term, I think Californians should advocate for increased funding for mental health services and increased funding for community-defined practices that address the needs of people of color, of LGBTQ plus communities, of low-income Californians. There are not enough services to meet the gap. And so we do need advocacy. We do need support at the local level, at the state level, at the federal level to really resource these services at the level that they need to be resourced. We cannot be healthy. We cannot be a healthy state if we're in a mental health crisis. And so we need to continue to prioritize mental health, or else it will have a generational impact on our children, and we will be dealing with this for many, many generations. So that's what I would suggest people can do, and that will help us be prepared for the next public health crisis, for the next pandemic, but it requires an intentional investment and sustained investment over time.
I also
That's-
added to the chat the Department of Mental Health webpage. There's a lot of resources on that page. There's also a helpline, which is 24/7 at 800-854-7771, which can provide mental health support, resources, and referrals.
Now, we do have some questions from the chat, and I'm going to ask actually Marcella if she's still there to maybe pop back on from AstraZeneca. These are vaccine related, but I'm going to throw it out to anybody who wants to answer them. The first one, somebody writes that they have an immune disorder and have received 3 boosters and wanted to know if, I'm assuming the AstraZeneca booster for people that are specifically immunocompromised would be something that even though they've been boosted, they should take a look at.
Yes, that is correct, Assembly Member Friedman. So if you have someone who is immunocompromised that have received your primary series and some of your COVID boosters, and to seek the advice of your physician, your provider, that they would recommend every shot as an added layer of protection as well.
So even if you've had boosters, this works in a different way. So you
Yes,
can
that's
still
correct.
have this.
Mhm.
Correct. Great. And somebody else wrote that they're fully vaccinated with boosters, and they wanted to know when we expect additional boosters. And do we have any idea of how often we're going to be getting boosted for COVID? I know that there's a booster now, I think that might have the flu vaccine as well. Is that what I read somewhere? I don't know if anybody wants to comment.
No, there's no combo vaccine, although I love that
Darn.
idea. I do believe that there's companies working on it, and hopefully for the next winter season. Both flu and COVID are RNA viruses, meaning they mutate rapidly, which I think we have all seen because we've needed to get boosters. We anticipate it will continue to mutate, so we will probably need to get boosters in the future. It's kind of impossible to predict when, but I hope for the sake of ease, it's something that's more like flu, where there's an annual booster to make it more easier for individuals to remember to get.
Great. And do you feel, any of you, that having developed the mRNA vaccine is going to lead to other vaccine breakthroughs that are going to be able to combat other viruses, other common viruses, even maybe the common cold at some point, or other coronaviruses? Or is this unique to COVID?
Oh, absolutely. I am so excited by the mRNA vaccine technology. I anticipate many more prevention of many more diseases will be coming. It's a great thing.
I think the benefit of the pandemic is the speed from the research to actually in market, and that's something, again, we've never seen before. How quickly it went from doing the research on it and then developing it to actually to market. And I think hopefully we'll be able to be much better and more facile at that, from going and looking at the pharma companies as they look to develop these things and how we get them through our own process. That I think that's been one of the benefits of this, is we've been able to move things much quicker and get it into people's hands much sooner, which is obviously a significant benefit for that.
So someone in the chat has asked about vaccine injuries. Is this something that you're seeing a lot of? And if so, what are you seeing and what resources are there?
Is this a reference to vaccine adverse events? I'm
I
assuming?
suppose I'm not exactly sure what they were referring to. It was a question in the chat.
Yeah, we have been collecting, we always collect data on adverse events that are related to vaccine. It's run by the CDC, called VAERS, Vaccine Adverse Event Reporting System. And it's something we're constantly looking for. Obviously, we never want to harm someone from vaccine. Vaccines have largely proven to be overwhelmingly safe and protective of disease. So it's something we're watching. For COVID, we haven't seen very many adverse events due to vaccine. I don't know if any of my colleagues want to comment.
From a provider that gave lots and lots and lots and lots of vaccines, the overall percentage is minuscule, extremely small. Now, things do happen and there are some reactions, but overall as a percentage, and how many tens of thousands, hundreds of thousands of vaccines we've given, we just haven't seen kind of any of those as significant injuries.
So what kind of thing, like you said, there's some minuscule effects. What would be the type of thing you would see out of those hundreds of thousands of vaccines you gave?
So you may have had a respiratory, or you may, quite frankly, we saw a number of panic attacks, especially right when we first gave them. People get panicked about it. And then you do have some of the symptoms that when that's part of, as you go through this, you might have some of the symptoms that you would have, and they're, could be either mild to moderate. So tenderness at the site, plus having some flu-like symptoms. And, again, it affected people very differently as we went through this. But from a lasting injury, we just didn't see many of those. Maybe some of the physicians can add to that.
So, from the state's perspective, would echo what Dr. Terashita and what Carl Keeler has said, very minuscule from a percentage to rise to concern. Another kind of sort of angle I want to kind of bring to that lens of talking about this is that it really highlights the question itself, and I also think the topic itself really highlights the importance of having trusted public communication and trusted messengers. Because I think oftentimes the stories where there were either an apparent injury or perceived injury, that it created a lot of concern and anxiety, maybe more so than it needed to. But because we needed to have trusted messengers, trusted messages, and also a system to be able to communicate that these are safe and effective, and that it was okay to get vaccines, it was an important lesson that we need to make sure that we maintain, that is always going to be a critical element of any emergency response, is that we have the trust of the public and that we give the tools and resources to our partners and providers to be able to do that in a timely way.
Great. And just circling back to the question of equity and marginalized or vulnerable populations, I would just throw out that it seems to me that one of the things that COVID and that any pandemic would show, and COVID has shown us, is that we really are only as healthy as the least healthy among us. That if you have people who don't have access to medical care, that not only are they at risk, but it puts entire populations at risk, particularly when disease is spreading. Or you have groups that don't trust vaccines, for instance, and don't get vaccinated. So I think that, it all does come back to equity and getting medical care, vaccine for everybody, but also medical care for everybody so that we all can be healthy. We do have a question. Oh, sorry, if somebody wanted to comment.
No, this is Carl. I think that's a perfect point. But as you look at that, for equitable healthcare demands, you have to have equitable healthcare kind of funding for it. And that's the one piece so you see in more disadvantaged communities and that are more reliant on Medi-Cal and other things, we haven't seen an increase in Medi-Cal for over 10 years. For us, we lose money on every Medi-Cal patient we see. It's 26% below, a shortfall to to what it costs to deliver that. So, that's the concern, is how do we make sure the most vulnerable get those resources, and that they're not disadvantaged just from a funding perspective as well.
Well, I think it does show the societal imperative to treat healthcare as a human right and as something that everybody is entitled to and can have access to. And I'll just end with this, because there was a question in the chat about long COVID and lasting COVID impacts. And I think we've been talking a lot about, what happened during COVID and what we're doing now. So what about in the future? What are we seeing with long COVID, and what is the plan to care for people, given that we don't know the long-term impact of even having had maybe a more mild case of COVID? Anyone want to tackle that? I know that's a big question in the last couple minutes.
I don't think you can go wrong with increasing the investment in our healthcare system and broadening our definition of the healthcare system to include more prevention, to, get it at the front end. And also just really, like you said, funding healthcare like it is a human right and not a privilege.
That is wonderful. So I think we have a minute just for any last comments that anybody may want to say, anything that we didn't get to that you'd like to communicate to the public. This is the time. Anyone?
Yeah, I would like to say thank you so much for giving us this opportunity to talk to individuals. I think communication is really key to stopping this pandemic. I did want to mention that winter is coming, as they say, and flu, based on the Southern Hemisphere flu data, has shown that we may have a big flu year this year. And we also anticipate, based on previous years, that we will see a surge in COVID. So I would like to remind everyone, please, please, please get your vaccinations for both flu and COVID. There's a new COVID booster out right now. It's called the fall 2022 bivalent booster. It contains both the Delta strains as well as the Omicron strains of COVID. If you've been following the different strains, you really need to get this to protect yourselves. And public health will give you the vaccine for free. To find a vaccination site near you, make an appointment or a vaccination at a vaccination site, and much more. You can visit www.vaccinatelacounty.com in English, or vacunatelosangeles.com in Spanish. And if you are homebound, you can contact Public Health Call Center 7 days a week at 833-540-0473. Please get vaccine.
Oh, and this is Carl, and I just, again, like to thank you for having these kind of forums. Absolutely. How do we communicate? How do we get the word out and highlighting these critical issues? So thank you very much for doing this. And again, I would echo, get your vaccines, both flu and other. That makes a significant difference as you talk about surges and need for staffing and everything like that. If you do those preventative pieces, there is no need for the other. And wash your hands. Please wash your hands. That is another just simple thing.
These are all great messages from our partners here. And obviously from everything that everyone shared, there are lots of avenues to get information, lots of avenues to get resources. So I'm going to add one more. If you're looking for just a one-stop shop to find where you can get your nearest vaccine, you can also go to myturn.ca.gov and do a search by where you live and find that as well. So yes, thank you so much for this forum. Really appreciate that we have this extensive network of partners to be able to talk about this issue that we all deeply care about. So thank you.
And thank you for including equity in this conversation.
And I would echo the same. Thank you for inviting us at AstraZeneca. Thank you.
Well, I want to thank all of our panelists. I learned a lot tonight, and I know that the public did as well. I'd like to thank Josefina Alvarado Mena, Carl Keeler, Dr. Carolyn Kurtz, Dr. Dawn Tereshita, and Marcela Seto-Chalk, all for participating tonight. And I'd also like to thank our teams, all of your teams, and also my staff who have been organizing this now for a couple of weeks, for all of their work. And most importantly, to the audience members, all of you are everyone who tuned in today are ambassadors about public health and about health into the community as well. So You're the reason that we're here, and I want to thank all of you for participating. As always, my staff is available to try to get any of your questions answered. You can put them in this chat online or send them directly to our office, and we can reach out to the panelists to get any answers, or anyone that we have access to get any public health answers that you might need. But you've got a lot of great individuals and teams and institutions working on your behalf here in LA County, and I feel very appreciative to all of you. So thanks, everybody, and have a really safe, wonderful night. And please do go and get vaccinated and take care of yourselves.